Today my topic is going to be on management of pulmonary hypertension, and then I will be touching you about the classification of pulmonary hypertension and the clinical classification of pulmonary hypertension and what are the drugs, what are the receptors that are, how it acts, and coming to the pulmonary hypertension. What is pulmonary hypertension? Pulmonary hypertension is the disease of the small pulmonary arteries that is characterized by vascular proliferation and remodeling, which is resulting in the progressive increase in the pulmonary vascular resistance and ultimately leading on to right ventricular failure and ultimate death. So, pulmonary hypertension is a disease of the small pulmonary arteries. The pulmonary hypertension is defined as a mean pulmonary artery pressure greater than or equal to 25 millimeters of mercury at rest, or it can be due to the diseases primarily isolated to pulmonary vascular itself, that is mainly you see in cause of idiopathic pulmonary artery hypertension, or it can be complication of a lung disease, that most commonly in case of an idiopathic interstitial lung disease like IPF, idiopathic pulmonary fibrosis, or any disease of the lung like chronic destruction of the lung due to pulmonary tuberculosis. They can also present with pulmonary artery hypertension, or a connective tissue disorder with interstitial lung disease can also present with pulmonary artery hypertension, most commonly in a systemic sclerosis or an SLE, or it can also be secondary to pulmonary thromboembolism, or sometimes it may be secondary to sleep disorder of breathing like obstructive sleep apnea can also present with pulmonary artery hypertension, or it may be secondary to left heart disease like left heart failure, or valvular heart disease can also present with pulmonary artery hypertension. And identification of its cause is essential, and it is appropriate therapy for pulmonary hypertension is aimed at the underlying cause. That is, for example, if you are thinking in terms of a interstitial lung disease related core pulmonary, that is pulmonary hypertension, you have to treat the interstitial lung disease as a separate part along with the pulmonary artery hypertension. So, diagnostic classification of pulmonary artery hypertension, as I told you, pulmonary artery hypertension secondary to idiopathic pulmonary artery hypertension where the cause is not known, or a hereditary pulmonary artery hypertension which is related to BMPR protein 2 or other unknown causes, or a drug induced or a toxin induced. Drug induced like fenfluramine or a rapeseed oil, all these toxins can produce pulmonary artery hypertension. Associated with connective tissue disorders, as I told you, it may most commonly seen in SLE, rheumatoid arthritis, or a systemic sclerosis. Most commonly they will present with limited form and a diffuse form. Both can present with pulmonary hypertension. In a limited form, most common presentation itself will be a pulmonary artery hypertension, or it may be a portal hypertension, congenital diseases, or schistosomiasis can also present with pulmonary artery hypertension. Pulmonary veno-occlusive disease or a pulmonary capillary hemangiomatosis is also one of the diagnostic classification of pulmonary artery hypertension. Persistent pulmonary hypertension of the newborn, or pulmonary hypertension due to left heart disease, or a pulmonary hypertension due to left ventricular systolic dysfunction, or a left ventricular diastolic dysfunction, or a valvular disease, or a congenital or acquired left heart inflow or outflow tract obstruction, or a congenital cardiomyopathies can also present with pulmonary hypertension. Pulmonary hypertension due to secondary lung disease or due to chronic hypoxia, that is most commonly seen in patients with COPD. That is a chronic obstructive pulmonary disease or an interstitial lung disease, or other pulmonary diseases with mixed restriction and obstructive pattern. That is in case of a chronic hypersensitivity pneumonitis, they can also present with pulmonary hypertension. Sleep disorder breathing, specifically for obstructive sleep apnea, and alveolar hyperventilation disorders. Chronic exposure to high altitudes or deep sea diving can also present with pulmonary artery hypertension, or developmental lung disease can also present with pulmonary artery hypertension. And other causes are chronic thromboembolism is one of the major cause of pulmonary artery hypertension, where if they have a major thrombus obstruction, they will have a sudden increase in RA-RB dilatation will be there, and they will have a severe pulmonary hypertension. Pulmonary hypertension with unclear or multifactorial mechanisms like hematological disorders like chronic hemolytic anemia or a post-splenectomy, they can present with pulmonary arterial hypertension, or systemic disorders like sarcoidosis, pulmonary histiocytosis X, or lymphangioliomyomatosis can also present with pulmonary arterial hypertension. Metabolic disorders like glycogen storage disease or Gaucher's disease, thyroid disorders, very rarely they can present with pulmonary arterial hypertension. Other tumoral obstruction, if there is a tumor obstruction into the vessels, they can also present, or fibrosing medial stenosis, most commonly in patients with tuberculosis of the mediastinal nodes. If you are not treating the patients properly, they will go for a fibrosing medial stenosis and later on go in for a pulmonary arterial hypertension. Chronic renal failure, segmental pulmonary hypertension is also one of the causes for chronic pulmonary embolism. And another classification is, this is the most important classification. According to this, the patient is getting managed. There is a WHO functional classification of pulmonary hypertension. Class 1, there is no limitation in daily physical activity, no symptoms of dyspnea with routine exertion. Class 2 is mild symptom with exertion, including dyspnea and fatigue, no symptoms at rest. Class 3 is moderate dyspnea with routine activities and activities in daily life, no symptoms at rest. Class 4, inability to perform even with minimal activities. That is at rest itself, the patient will be very dyspneic and tachypneic, and they will have signs of right heart failure, and they will present with severe dyspnea at rest with pedal edema. So, these are the functional WHO classification of pulmonary hypertension. So, what is the most common clinical symptoms in pulmonary hypertension is, most commonly they will present with abdominal distension in first person, and most common presentation is a dyspnea and exertion is the most common presentation, and the second common is a fatigue. They can present with pedal edema, they can present with dizziness, cough, they can present with syncope, they can present with palpitation. So, these are the most common clinical presentation of pulmonary arterial hypertension.